can a shot of your own blood actually cure painful sex? I know, it sounds like straight up science fiction, but this exact concept is at the absolute forefront of a massive trend right now in regenerative medicine for intimate health. If you, or maybe someone you know, has ever struggled with sexual discomfort, you've probably heard whispers about this thing called the O shot. But once you get past all the flashy marketing, what's the actual science here? Does it work? And most importantly, is it safe?
Welcome to today's Explainer. I am so thrilled to guide you through this. We're taking a really structured, completely objective deep dive into the O-shot and its connection to a medical condition known as dyspareunia, or simply put, painful sex. We're going to cut through the noise and look strictly at what the clinical data, the medical guidelines, and the anatomical science actually have to say.
Here is our roadmap for today. Understanding painful sex, the standard care pathway, enter the O-shot, the clinical evidence, the treatment experience, and making an informed choice. Let's dive right in. Section 1, Understanding painful sex, defining the problem. Okay, before we jump into any novel treatments, we really need to set a baseline. Dyspareunia is a clinical term for persistent or recurrent genital pain that happens just before, during, or after sex. And the medical literature makes it very clear this is a highly complex, multifactorial condition. It's definitely not just a physical issue. It carries a massive emotional and psychosocial burden that literally impacts a person's physical functioning and their relationships. It creates this vicious cycle, right? Pain leads to anxiety, which causes muscle tension, which, you guessed it, only leads to more pain. Looking at the clinical breakdown of this, the sheer variety of triggers is wild. Just running through the list, it can be driven by physical problems, infections like thrush, or psychological factors. A huge driver here is vaginal dryness, which is heavily associated with the dropping estrogen levels of menopause, often called genitourinary syndrome of menopause, or GSM. The breakdown also highlights vaginismus, which is a severe, involuntary tightening of the pelvic muscles. So, there's absolutely no magic pill for this because there's no single cause. To actually figure out how treatments are targeted, we have to categorize the pain. Doctors generally split dyspareunia into two distinct types, superficial and deep. Superficial pain happens right at the entrance during initial penetration. This is where you see things like that menopausal dryness, skin disorders like lichen sclerosus, or the muscle tightening we just talked about. Deep pain, on the other hand, is felt much deeper in the pelvis during thrusting, and that points to completely different internal issues like endometriosis, fibroids, or pelvic inflammatory disease. Getting an accurate diagnosis here is absolutely crucial because it dictates the entire treatment path. And just to be clear, the treatments we're focusing on today, like the O-shot, are primarily aimed at that superficial pain caused by tissue thinning and dryness. Section 2, the standard care pathway, stepped medical foundations. So when someone goes to their doctor with superficial pain, they don't just jump straight to needles. Medical bodies like NICE over in the UK have a very systematic sequence. Step 1 is all about non-hormonal foundations. We're talking about using a scheduled vaginal moisturizer, like a hyaluronic acid gel a few times a week, combined with a really high-quality lubricant during intimacy. If that doesn't fix it, we move to Step 2, local vaginal estrogen or DHEA. This actually addresses the biological root of the tissue thinning, using localized hormone replacement. It's only if those symptoms persist after doing all the basics diligently that doctors start looking at Step 3, adjunct or add-on therapies, like platelet-rich plasma. Section 3. Enter the O-shot, regenerative adjuncts. Well, what happens when those foundational treatments just aren't cutting it? Or, what if someone simply can't use hormones because of a history of breast cancer? This is where the O-shot comes in. It's a branded application of platelet-rich plasma, or PRP. Actually, let's de-jargonize this for a second. Autologous simply means it comes directly from your own body. PRP is made by taking a tiny sample of your own blood and concentrating the platelets. These platelets are packed with growth factors. Think of them as tiny biological messengers that literally tell your body to repair tissue, build new collagen, and boost blood flow. By injecting this localized burst of healing factors right into the vaginal tissues, the ultimate goal is to naturally rejuvenate the area, boosting both lubrication and sensitivity. So how does this actually play out in a clinic? It's honestly surprisingly straightforward and minimally invasive. Step 1 is just a standard, small blood draw from your arm. In Step 2, that blood goes into a centrifuge. It spins super fast to separate the red blood cells from the plasma, isolating that liquid gold concentration of platelets. Step 3 is a big one for comfort. They apply a strong topical numbing cream to the intimate area. And finally, in Step 4, the doctor does precise injections into the clitoris and the anterior vaginal wall. Section 4, the clinical evidence, looking at the data. The whole idea of using your body's own healing power sounds amazing, right? But mapping out how researchers actually evaluate this is pretty intense. Looking at the rigorous screening process from a recent systematic review, scientists started with nearly 400 potential medical records, but then they ruthlessly filtered them, removing duplicates, tossing out non-clinical data, ditching studies with incomplete results, until they whittled it down to just 17 high-quality studies for the review. It really highlights that while the buzz around this is super loud, the pool of strictly controlled, high-quality data is actually still pretty narrow.
When we actually dig into those remaining studies, we find this fascinating balance of real promise and, well, caution. On one hand, the reported benefits are genuinely exciting. Early trials are noting significant improvements, showing increased sensitivity, improved natural lubrication, decreased pain, and just better overall arousal. But we've got to ground this with the clinical caveats on the flip side. The scientific community points out that these studies often have super small sample sizes, the results can be pretty mixed from person to person, the effects are temporary, and honestly, we still desperately need large-scale, double-blind randomized trials before anyone can call this a definitive medical cure.
Section 5. The treatment experience, practicalities, and costs. So, if a patient and their doctor weigh the pros and cons and decide to go for it, what's the actual logistical reality? It's incredibly fast. We're talking about 45 minutes door to door. Pain is generally reported as minimal, mostly just some brief pressure, thanks to that numbing cream. There's virtually zero downtime. You can resume normal activities, including intimacy, the exact same day. But we have to talk about the cost. In the UK, for example, you're looking at roughly £1,150 to over £1,425 out of pocket, since this is a private procedure. And as for longevity, biological repair takes time. The effects usually peak around 3 months and last maybe 12 to 18 months, meaning it's a maintenance therapy for sure, not a one-and-done fix. Section 6. Making an informed choice. Next steps. It's really vital to understand that even though PRP uses your own blood, it is definitely not suitable for everyone. There are some strict hard no's for this procedure. Anyone with an active infection, like thrush, bacterial vaginosis, or a UTI, has to get that resolved first. If you've got severe, undiagnosed deep pelvic pain, this shot is not for you. Remember, deep pain usually signals internal issues that injections just can't fix. Unexplained postmenopausal bleeding absolutely must be thoroughly investigated by a doctor before touching any regenerative procedures. And, of course, pregnant individuals and anyone with poorly controlled bleeding disorders should definitely avoid the treatment. I really want to highlight this quote from the medical oversight team at the Women's Health Clinic. They kind of hit the nail on the head, stating, "Individual suitability is determined by a clinician. Results may vary, not a cure." That perfectly grounds everything we've talked about today. The O-Shot is a really exciting emerging tool. For the right person, maybe someone who has completely exhausted standard moisturizers and local estrogen, it can offer a really meaningful return to comfort. But it absolutely requires realistic expectations and a proper medical consultation. So we've covered the definitions, the standard pathways, the biology of PRP, the hard clinical data, and the real-world costs. Which leaves us with this final thought. How do you view the role of regenerative medicine in treating intimate health? Does the incredible potential of using your own biology outweigh the reality of the emerging data and that pretty hefty price tag? It's such a fascinating intersection of science and personal well-being. Thank you so much for joining me for this explainer. Keep asking those great questions, and I'll see you next time.